Well, Anthony wanted me to be a little bit more energetic, and I think that's about the only thing that's giving me away right now, trying to cause trouble. So let's go. All right, so I put the elephant here. This is one of my favorite slides. I think, however, from whichever aspect you look at it, well, we're all blinded men feeling the elephant. We all see part of the problem, but at the end of the day, if we ever want to really consider our patients, and I am, this is AI Med conference, so we are anchoring on medicine and healthcare delivery. So if we think about this, what is our ultimate goal? Our ultimate goal is to be able to understand our patient as an individual, not just as a clinical diagnosis. We know the medical record gives us the information that makes the clinical diagnosis, and we all rely on it, and there are all the problems we heard about. It's far from being perfect, but even if it were perfect, we know that it doesn't capture everything. We know for a long time that behavior matters. We know smoking is bad for you, and now your grandma's right. What you eat, how much you sleep, whether you exercise or not makes all the difference, and guess what? We have the tool now to know them. We know that your clinical phenotype is linked to your underlying genetics, not just your germline, but somatic genetic, and before you know it, there is the microbiome, everything else that's on you. There are many genomes that matters, and we know that with the technology today, we will know everything you do. We can track them. There are lots of data, but we also know that we are not, most of our clinical phenotypes are not independent. It is dependent on the environment, and we know the environment matter. We know sun exposure matter. We know environmental toxins can cause disease, and we now know that social determinants contribute tremendous amount to the overall health and outcome of the individual. So what we need is being able to make sense of all this and make use of all this data, because technology has advanced in such a way that we can generate this data. And now, AI and MI, I said I wouldn't start the sentence with a word.
It'll be $1.
Oh, one down. He got $1. A drink. Let's do drinks. Okay. Okay, so therefore, we are looking toward analytics, sophisticated analytics, and we put them all under this big umbrella of AI and machine learning to help us make sense of these data and make use of these data. But I want to step back and say, let's not stop there. Patient will not, at the end of the day, benefit from AI, machine learning, or data for that matter. They need a lot more. I put this diagram together just to make the case. Okay, we have our technology, whether it's IoT devices and apps and novel diagnostic tests that generate data, like sequencing data. And they give us raw sequence data, and we know there's a lot of analytics that have to go in to make sense of that data and turn it into something we can use, like mutation calls, whether a cancer has particular mutations. And there's all kind of analytics that need to go in there, and if you want to call it AI, that's fine. There are other analytics that still work, that have come through decades of computational biology and data science. They still are useful. But what you do is that just knowing a patient has a EGFR mutation in their lung cancer, or just knowing that the patient's hypoglycemic, isn't really all that the physician needs. What they need is that now they need to synthesize all this information, put it together, and contextualize it. It does matter whether that is a woman, 30-something, Caucasians, non-smoker, or Asian smoker. That makes a difference, whether you're interpreting the tumor that's EGFR mutant or not. It matters whether the individual is a single mom living in a rural community, and you can never expect her to go and get IV therapy every 3 times a week. So those are the things that physicians have to do to bring it all together, to make the decision, and then ultimately, you also need someone to act on it. I mean, analytic insights really does not treat patient, does not help patient, by itself cannot generate any real value. We need a workforce, and we already had conversation earlier today about trained workforce that's needed to take all of that information and convert it into actions. And then also coming back to a little further to the beginning, we also need not just one analytic, but many, not just one test, but many. So we need choices and options, because we really, as a community, as a society, we need that competition that allow us to drive to better value and lower costs. All that really means is we need to be able to integrate all these things together. There is no single point on this graph or whatever graph we want to make that by itself will achieve the outcome that we're looking for. So we need to be able to integrate, and that's where I think infrastructure comes in. The analogy I make is like having 10, 20, I actually don't know how many automobile manufacturers there are, but there are more than 10. And then there are, motorcycle manufacturers, there are big trucks. These are all vehicles that ultimately, and bicycle, they can all go, they need road to allow them to do their things. Imagine that there is no interstate highway, and you spend money and buy a Tesla. It's not going to do you much good, because you're not going anywhere. Now think about also that the highway only works for a Toyota. It doesn't work for a Chrysler. That doesn't work either. What we need is that infrastructure that allow us to benefit from all these capability, and I think that's what we're missing in healthcare. We need an infrastructure to connect the new and the old, connect the analytic, the data, and ultimately the people. But if you think back to the highways analogy, it is not just the concrete and the on-ramp and the off-ramps. It is a lot of the non-technical stuff. Who should be given a license? How do we educate and train them so they can allow to get behind the wheel and get on the highway? My middle child just got her license last week, so I feel strongly about this one. They better be trained before they get up there. Who's going to monitor? How do we know that you should be driving on the right side and on the left side? And how are you going to monitor? Who is the patrol? All of those are things that need to be there, and we're going to spend a lot of time today talk about that. How do we ensure that you can trust and have transparency so you will use the infrastructure to facilitate everything else that we talk about? And then finally, I think one of my experiences in healthcare, we want to ultimately engage the user, the patients. And guess what? They really don't like to be engaged if they don't trust you. And we can't have trust without transparency. And transparency, at the end of the day, means data. And that's the data conundrum that we're talking about. I will start the discussion with the example of a project that we've been doing the last several years, which is going into a community that happened to be the #2 poorest city in the country, in the Brownsville, which is now very famous thanks to our immigration problem, right along the Mexican border. We went in there and brought together entities that are public and private, large and small, regional and global organizations. And the idea is that we need a different model because we know data exists in all of those places, generated by all of those organizations. And if we want to know everything about the individual so that we treat them as a person, not as a clinical diagnosis, we need data from every one of them. Coming from 15 years of working in the cancer genomic community, I actually don't think we can simply say open and sharing. I mean, that's easy to say, but it doesn't work without getting down to the detail. So what we wanted to do is go in and say, what are the infrastructure that's necessary? How do we bring a data aggregation platform together that I happen to believe need to be neutral and third party, not sort of more agnostic? It needs a lot of things that have nothing to do with technology. That's necessary to balance out the liability and responsibility and operation between a very small entity like a federally qualified health center and a Fortune 1 company on the other side. But the truth is, you have to solve that problem, and you have to deal with the liability that comes with that, and because the data is not free. Data has a lot of value to it for good and bad, and therefore you can't treat them as just free. And what we did is that once we create that connected ecosystem in a community, we can then design workflow. Because healthcare isn't transactional, at least we don't believe it should be. There is no one single act that delivers the patient outcome, and therefore we need to coordinate. To coordinate that, we need a framework. And what we have developed is sort of what we call READY, and for those of you who may be familiar with the patient-centered medical home, I think of it as the next generation. How do we create that model that allows us to create workflow from preventions to acute and chronic care, all the way to post-acute care monitoring and so on. But what we have learned in making this happen is to engage the patients. To do that, you need permissions and you need trust. In other words, you try to go in there as a large company or as a payer and try to go up to the patient and tell them they should share their data and tell you whether they're having a problem at home that make them skip their medicine and not be able to fill the prescription. Well, they're not going to talk to you as a payer. There's a certain brand permission, and in fact, that's one of the things that we learned, that as a public institution, the University of Texas system, we have that brand permission to be able to serve as that patient advocates, and that's a really important thing to establish trust and engagement. So with that as a background, I'm going to invite my panelists to join, and unfortunately, John is not going to be able to make it, so we'll just have a lot of extra time. We're going to first hear from Bernard on an example from the hospital that he worked on, and then we're going to talk to Sam about how we're going to pontificate on security and trust.
How are you this morning? My name is Bernard Brooks, and I'm a director of clinical analytics at Flagler Hospital in St. Augustine, Florida. And so certainly send you all a welcome from St. Augustine, Florida, the official oldest city in the United States. And
Really?
we certainly, if you ever visit, welcome for you to come and take a visit. Just to give you a brief idea about Flagler Hospital, and when I mentioned the oldest city tongue-in-cheek, let you know how new we are to the space of electronics as far as medicine is concerned. It's only until the year 2013 that we got involved with an official electronic medical record. Before that, it was a mix of paper records and an older legacy system that clinicians use to treat their patients. But we're kind of new to this space. We partnered with Allscripts as our electronic medical records, and just a few years later, here we are in 2018, and we're trying to take on clinical variation management. So just to level set a little bit, I want to talk a little bit about clinical variation management, what it is, why we tackled it. Obviously, as a hospital, our primary interest is in taking care of our patients, trying to get the best care as possible. But we are a relatively small community-based hospital, and so for us, cost containment is a big deal. And so we need to do so in the most efficient fashion that we can. So when we talk about this idea of clinical variation management, for those of you who may not be in the hospital space, maybe a little bit more technically inclined, just want to define that for a moment, maybe by expressing what it is not. So if you talk to many of the physicians that are in the room, they still, even today, will refer to the fact that medicine is as much an art as it is a science, still even today. And the art part that they're referring to maybe could be exemplified by a surgeon who uses his years of training in an emergent situation and comes up with a very creative solution to solve a problem that they didn't anticipate. And so that sort of creative thinking, using their expertise on the fly, is a form of variation. It's a form of clinical variation, but that's not what we're talking about when we speak of clinical variation. Clinical variation in the hospital space is looked upon a little bit more negatively. It generally refers to waste in our health system. And there was an Institute of Medicine study in 2012 that came out that estimated that about 30% of the healthcare dollars in the United States, which is roughly about $750 billion, is complete waste. And so clinical variation to us has a little bit more to do with treating populations of patients that have similar characteristics in very different ways, often in wasteful ways. And so it's the overuse, the underuse, the different use, and getting all sorts of different clinical outcomes for that care. So that's what we refer to when we say clinical variation. And so just a quick profile of our hospital. We are founded in 1889, as you see there. We're a completely not-for-profit hospital, about 300 35 beds, about 400 physicians, but the notable key point there, 0 employed staff. All of our physicians are community-based. They all have their own practices. They come into the hospital to see their patients. And we are a very small team. We're an informatics team of 5, including our CMIO, who's kind of headed up this project. And just to show you how small we are, I am a director of 1 for analytics. Small hospital indeed. But we wanted to get into this idea of clinical variation management, and we got introduced to it through the medical literature. As it was mentioned earlier, artificial intelligence has been brought up as new in this space, and our CMIO found an article about it in the literature and wanted to explore it. And we found this one company from here in California called IAs Dee, who was pioneering this idea of clinical variation management using artificial intelligence. So we reached out to them, and they came and did a demo for us, and we were highly impressed with their product. And one of the things that most impressed us was, to the doctor's point, was how you could take the information, analyze it, but then do something about it. And that's what really stood out for us about IAs Dee. And just to speak a little bit about what the technology does for us, IAs Dee is a tool that explores clinical variation management using unsupervised machine learning, which essentially allows us to curate our data, as was mentioned earlier, send it over to their platform, and analyze it to detect patterns in the data that we normally would not see. I'm a SQL developer myself, and so what the precursor to this project that led us into this chasing after clinical variation management were a few predictive models that I had written that turned out really well for us. For example, I wrote a model in conjunction with our CMIO to try to predict CLABSI, incidence of CLABSI, which for us is central line associated blood infections. And we went from having about 15 CLABSIs a year, those infections from a central line, to 0 when we implemented the model, because it had a scoring mechanism that helped us to see this patient is at risk. We put that intelligence at the nurses and physicians at the bedside, and they almost eliminated bloodstream infections in our hospital. So we said, could we take it a step further? And with this application, what it allowed us to do was something that would take me 2 years to build, which is looking for patterns in our data. Problem with part of this data conundrum is looking for things that you don't really anticipate. And so the way IAs Dee works is that it takes your data, transforms them into treatment groups, and then allows you to drill into those treatment groups. Here's an example of what IAs Dee did for us. Over on the left, you'll notice these treatment groups that were created from our data, and this was for a pneumonia data set. And basically, it gave us some common measures that we look at: length of stay, various comorbidities, what's the average direct variable cost for our patients, and readmission rates. And over on the right are just a common Excel graph. We took those groups that IAs Dee presented to us, and then our physician group could quickly determine what groups do we want to analyze. Cohort 41 that you see there on the right helps us to see there is 0 readmission rate, 0 mortality, and a relatively low cost for that patient. So our physicians drilled in on this group and began to analyze it. And a few insights came out of that analysis. One of the things that they quickly discovered is in the treatment of pneumonia patients, the patients in that group use antibiotics fairly early on in the process in the emergency department. There was also an interesting anomaly that steroids were being used more frequently. and the timeliness of their blood cultures being drawn was done. So as we drilled into that group a little bit further, and our physicians started to think, well, why could this be? It's a possibility that our respiratory therapists, who often administer respiratory treatments, nebulizers in the ED, stay with the patient throughout their care at our hospital. So this is a potential reason why the AI was showing us that. We weren't sure, so we decided to drill further. One of the things that we can do once we had this analysis here is then create a care path. Again, this is with the AI tool. And one of the things that IAs Dee does very nicely is that once you get that one treatment Goldilocks group, as we call it, then we can say, present to us a care path of all of the events they had in common. And as they analyze this, this is where we get to transform things into action. We took the clinical human intelligence, blended it with what the AI tool was telling us, and then started transforming it to action. What you see on the right is a picture of our clinical order sets for pneumonia. And the care path informed us that we had a lot of waste in our system. In this particular instance, we had 5 disparate pneumonia order sets that were being used in all sorts of different ways, with different medications, all sorts of nursing orders, and duplicative orders throughout the sets. And so we were able to take this care path, reconcile it with our existing order sets to create one single order set for our clinicians to use. And this really is a point of emphasis that I want you to walk away with, that it was stated earlier that the curation of the data is one of the hardest things that you'll have to do, and that is true. But I would argue that the implementation could be a step harder, because this is where we're taking the information and creating action out of it. And there is a ton of work in this part of the program. This is where you need to get your clinicians involved, change management involved, all of the order sets remodified, training physicians how to use the new order sets. And there's just an entire infrastructure involved in trying to get that change management working. And so here are some of our early but promising results. We started in about February, and now, after in our 4th quarter, although we have a small number of patients with pneumonia, we had some promising results. Comparing those who used the new order set versus those who did not, you notice immediately that there was almost a $2,000 savings, the direct variable cost per patient, for those that used the new order set. There was also almost a 2-day length of stay less. The readmission rate is a little bit higher. We're not exactly sure what that is yet. That equates to about 1 patient. But these early results were very, very promising to us. And so this represents almost a $200,000 savings. And as we project it out, we think that we could save millions of dollars in the next few years. So,
Okay. Can I interrupt a second?
Sure, absolutely.
I think we have to move on. Thank you for the example there, which is really showing how, at the end, to know what data to use and how to act on the insight from the data really need a human expert. But I want to make sure we have time to hear from Sam.
Let's talk about data. Just quick introduction myself. I work in healthcare for about 30 years, of which 26 years in data. Start with mainframe programming, look at 1,000 columns data, count them, not manually, of course. And used to be in epidemiology research, so I do a lot of cancer, injury, all sorts. So data is something, notes to musician, to me, that analogy. So hopefully I will utilize the next few minutes, just share a couple of thoughts about data, and then go back to our panel discussion. Big data, right? Last probably 6, 8 years, we heard every day, every moment, how big it is, the volume, velocity, virality, variety, all these different things. Huge. Just look at this. If a human body is a source of big data, we're looking at terabytes worth of data from anywhere, right? Radiology, from your determinants of health, from your daily activity, you name it. Some estimate a couple of years ago, probably a year ago, is 665 terabytes worth of data for a person, okay, for a person. This is another angle to look at. If you look at healthcare data, we're overloading definitely 60%. And you look at determinants of health from volume, again, velocity, variety, and all these things. Genomic data, 30% of, again, determines health, so on and so forth. So I'll move on. I want to have this takeaway, and this, I know, this conference and any other conference will tell you wonderful tools that are available to you for data, for analytics. But one thing we need to take away and keep reminding ourselves is we're actually not just in a patient business, in curing patients, in curing disease. We're in information business. Okay? This is from smart people, not just from me, but some smart people tell us, and this is coming from decades of experience they have. So when we look at the data, one of the key things we need to pay attention to is, do we have capacity? Do we have infrastructure to deal with that? One of the most research come out of ConRes, that company. They were estimating about 25% of IT workloads is going to be in AI. A quarter of them, think about that, a quarter of them, right? Whether it's computing power, staffing, so on and so forth, of which 60% is related to deep learning. I managed to not say AI in my sentence starting, so successful, right? Still have my dollar here. All right. In the meantime, when we think about hardware infrastructure, so storage, processing power, whether it's cloud-based or local data center, we also forget sometimes about the soft skill, right? So many of you probably likes to do Sudoku, right? 9 by 9 is by far the most challenging one. Well, this is what I call the new Sudoku. Right? Anybody recognize what kind of data is that? Now, this is not a makeup one. This is where I was doing a consulting project for a large organization, billions of dollars worth of revenue. They spent probably $1 billion in doing Epic implementation. Yet, this is after Epic phenomena. They have this data. Anybody recognize what kind of data you're looking at? Something about IP inpatient or outpatient, some sorts of thing, right? ER numbers. So a well-known leading-edge organization still have same problem we're dealing with, whether you're community hospitals, whether you are critical care hospitals, whether you're a $50 billion company, you're dealing with that every day. Handwritten notes, EHR notes, right? Structured, unstructured data. So how do we do this? We keep thinking sometimes, we need a magic. We need a CIOs. We need a CTO to help us. We need to buy loads of those servers and computing powers. One research really caught my attention, which is from an AI standpoint and any technology implementation standpoint, many of you probably recognize several years ago, in the US at least, when we started doing IC10 implementation, CFOs typically, I'm a finance guy as well, so I deal with a lot of finance side of that. CFO would typically say, you know what, for ICD-10 implementation, go talk to my CIO. He will get something, solution for you. They forgot it's not just CIO issue, not just technology issue. So this is another validation to that. You look at a top green bar, right? Blue bar is bottom, green bar is bottom. For those AI projects, if you look at it, mass majority, 59, 65, from initiating it and efforts of AI, makes technology decision, approve funding, most of that, 59 and above, are made by non-CIOs. Could be CMIO, CFO, other things. So think about that. Like Anthony was saying, we have about a 50-50 split, roughly 50% clinicians here, another 50% non-clinicians. We need to make sure that we are driving that transformation of AI using data, using whatever that decision we need to make. This is the one last message I want to take away, which is when we talk about AI, oftentimes we think about cool technology, like cutting edge. Think about what is the organization needs are. Can we actually utilize, train our staff, train our workforce to be analytical minded, to drive that? And I'm sure we'll have a lot of discussion about that. So that's kind of my sharing thoughts I have. So thank you very much.
So, thank you, Sam. So you've heard a couple examples where clearly the case where we need the expert to really understand what data to pursue and how to take that insight from the analytic, from the AI, machine learning analytic pattern to turn it into actions so that they can produce the outcome in the case of Flagler Hospital. It is being able to achieve cost saving, and then we hear from Sam that the capability isn't just about hiring your CIO or implementing Epic or getting a fancy, cool analytic technology. At the end of the day is being able to bring everyone together. And what I have tried to make the case for is, in order for us to get over this data challenge, because your AI machine learning algorithm needs data, that we need to come and start thinking about infrastructure capability that allow us to aggregate the data and allow many users of that data. Because the problem, if we start from the end point, you will ask what data you need, get the data you need to answer that question, but all the work that had went into getting that data is not being reused, as opposed to being able to allow data to be aggregated and then have that data be used. But to do that, we're going to need the infrastructure, and I also believe that we need to have an agnostic infrastructure that is built to facilitate what I call digital highway. And I want to open up and see if there's any questions on that front, because I think that speaks to some of the question that was raised in the earlier session today about some of the very, very basic stuff that may not be shiny and the coolest thing, but they're rather very important for the overall infrastructure or operation, I should say. Anyone? I'm going to keep talking until someone step up and ask the questions. And so I want this session, this panel, to be about challenging the mindset, or at least challenging you to think not just about those fancy, cool analytic or solutions or insights, but think about the infrastructure that really allow data to produce a maximum value in care delivery. Is there a hand?
We have a question over here. I'm afraid we
okay.
only have time
Go
for
ahead.
one question today.
Well, thank you. My name is Valerie Reed. I'm a radiation oncologist in Houston. And as a clinician, I had a question about how you could deal with the potential for alert fatigue with all of these algorithms coming up. Like, what if, for instance, you get an alert, every patient is at risk for sepsis, and then if you get it all the time, the clinicians might not respond the same. So what's the potential to help with that?
So I'll give you answers that sort of a little bit more from personal experience, and that's a lot of complaints from user of these analytics. And this is where collaboration needs to happen, or where the clinical expert needs to sort of play a bigger role. The technology analytic company will build this capability, and they look toward published guidelines. And they say, if you are above, blood pressure 130, or now 120 over 80, you have high blood pressure, and therefore now you get an alert. And we know that's not going to be really good for the physicians. Instead of a physician saying, well, what I need is an analytic that allow me to say, for this patient, I'm happy if it's 150 over 90, because that's his baseline, and that's the best I can do, at least in the current time. And I need your tool to give me that ability to either manually set that for the patient, or look over the last 3 weeks or 4 weeks and set a baseline and only alert on it. And that's doesn't sound like it's not very sophisticated and is technically not very hard, but the gap there is the difference between approaching this as an engineering challenge versus a clinical problem that needs to be solved. And I like to say that that's an example where I would use to say why clinicians need to be in the driver's seat to develop these capabilities.